Hello, and welcome to Everyone Dies, the podcast where we talk about serious illness, dying, death, and bereavement. I'm Marianne Matzo, a nurse practitioner, and I use my experience from working as a nurse for 45 years to help answer your questions about what happens at the end of life. And the staff at Everyone Dies is taking a much-needed break this December, so we will be republishing some of our greatest hits with updated topical information as an introduction. This week, we're going to talk about palliative care and how one family thinks about palliative care. Today, I'm talking with Connie Baker, co-author of the Wong-Baker Pain Scale, the one with the faces. As well as having a cancer diagnosis herself, she talks about her father's advanced cancer and how to help people have a voice in their care. Let's have a listen. Today we're going to be talking about resilience, especially in the face of, advanced cancer, people with advanced cancer, incurable illness, and how we work that through with our families, our parents, people that we love, how those decisions get made. And so our guest today is Connie Baker. And Connie Baker is the author of Stay On, which is, the subtitle is Building Resilience and Thrive While Facing Cancer. So Connie, welcome to our show.
Thank you, Marianne. It's great to be with you.
So Connie, God, we've known each other for, going on almost 20 years through a variety of different connections over time. And most recently, I don't know how we started chatting, but your dad has been diagnosed with cancer. And we had some discussions about, so what's going to happen next? Do you want to tell that story?
Sure, I'd be happy to. So my dad has several issues going on with his health, but he's overall very strong, vibrant, loving, has a great community. But he was diagnosed with an aggressive form of prostate cancer, and it's just been an interesting process as we've gone along. We're really blessed in our family because we have, there's 4 children, 3 of us are in the metro area, and we all get along well. We do different things. We don't always agree, but we have a lot of love and good communication. And above all, we want the very best for our parents. So in the process of being available to my dad, we would frequently go before COVID with all the family members, and somebody would be taking notes to the appointments with his doctor and really doing our best to communicate about what was happening with the extended family. So I would usually be the scribe, and I would write down what we learned in the appointments and then share that with the larger family. Mm-hmm. And it was one thing that we did that I talk about in Stay On is we created a notebook that was very helpful that that has different sections for, medical information or articles or emails from people or just whatever you might need to grab to keep an organized approach with the care that's involved. Because for my dad, there were a lot of doctors involved, like an endocrinologist and others. So that often complicates the story just a little bit. Mm-hmm. But then what we discovered is as things progressed, he did well, but he had some side effects from the medications, and then at one point discovered that his cancer had spread quite a bit to the bones, and then there was discussion about how much further treatment to have, and that's where you and I began talking, and that's when we start talking about quality of life, mm-hmm. and what are the side effects of the medications, and how effective are the medications, what are they going to do for him, and is it worth the side effects? And ultimately, it took a little there was some dancing that goes on, and that I think is often what happens with family dynamics. There'll be some who really want to go for the treatment, and some who are saying, I don't know if the treatment is the best thing. And also, of course, incorporating what Dad and Mom wanted to do. That was most essential. And I find just in my own experience, having had cancer myself and then working with other people with cancer, is that when cancer patients defer judgment to their family members or other people without having a voice in it, they have less peace, it seems to me, and less contentment with the outcome. Because
now, wait
none
a minute.
of us
Explain that.
What?
Explain that more to me, because I don't quite get what you mean.
Okay. So what I mean is, I feel like patients need to have a voice in their care.
Ah, okay.
And so sometimes I have people in my life who have delegated the decision-making to other people, but then when they got to a point where they wanted to be a part of the decision-making, they resented other people making decisions without them being a part of it. And so I think to the extent that they are able, if they're too sick or if they are not able to help make decisions, and that's one thing, but to usurp somebody's personal power in that moment, I think that's kind of a perilous decision.
Mm-hmm.
I encourage as much communication as possible, and we really did that. And it takes patience for some people, and sometimes you just have to wait. And I think that's where the resilience comes in. And when I talk about resilience, one of the things what I mean is, resilience is our ability to bounce back after something happens. And when you're dealing with a health challenge, that resilience issue happens. That opportunity to show resilience may happen every day. Mm-hmm. And so building resilience in your life is critical. And I do that through a simple technique that I learned through heart math. I don't know if you're familiar with heart math, but it's
I am, but I don't think our listeners are, so if you don't mind explaining that.
Okay, so it is a system of techniques and tools that we use to help people learn to self-regulate their response to stress. And as we practice these simple breathing techniques and do that on a regular basis, it really changes the way our brain works, and we're able to not react to situations, but self-regulate our stress response. Mm-hmm. And it happens, the techniques are so simple that you think nothing is happening. And that was my experience when I learned about it 10 years ago. But having learned that 10 years ago during a time that was extremely difficult for me and seeing the transformation I had in my life, I just continued to use it, and then was diagnosed with breast cancer. And when I was diagnosed, I thought, oh, okay, I have the tools that I need for this. I have built up the resilience that I need to be able to respond to the things that come my way. And that has been my experience. The same is true when I deal with my, as we work as a family to help our parents. With resilience, we can just be good listeners and respond and have ideas that will be best for everyone.
Now, was your dad willing to have those conversations with you guys?
Yes. He was willing to, he was very willing to talk. In fact, he was very engaged in the process.
Now, did you find that the oncologists or any of the oncology specialists were kind of pushing him or the family toward treatment, or how was that approached?
Yes, there wasn't a lot of treatment at first besides a shot to decrease his testosterone, and he had some radiation. Mm-hmm. And so those things went well. He had already had some of the cancer had gone to his bones, so that's what they were radiating as well as the prostate. And then at one point we weren't getting all the information we felt like we wanted. And I think I know, and you helped me a lot with this. I wanted to understand where the cancer was. We knew it had spread, but we didn't know to what extent. And I thought that would be helpful information to know. And you said basically why. And that was really a helpful thing for me to hear, because for me, I thought, well, if I know it's in his bones, then we can be careful that he doesn't fall. But, let's just be careful he doesn't fall. Right? So
exactly right.
I mean, it really just made a ton of sense. Plus, when they're older, having to drive a ways and need several people to go with you to make these appointments, it's very difficult. Mm-hmm. What we found also is Dad had several different problems going on, and our healthcare is so specialized that if you say, I've got prostate cancer, but I'm also having some rectal bleeding, and the prostate doctor says, nope, I just deal with the front part, I don't deal with the back, mm-hmm. then you've got to go to a different doctor for that. And it feels like a constant process, and that is not where they want to live their life. They don't want to be at the healthcare center. They want to be with the people they love. So that, that made a big difference. And then at one point we did get a second opinion, and that doctor did want to do a lot more treatment with Dad, and the side effects would exacerbate the symptoms he was already having. So we just let Mom and Dad really come to the decision themselves after we talked about it and read the side effects, and they chose not to do more treatment. And Dad is really doing well. He's thriving considering all that's going on with him, and they're happy together. For a period of several months, they've had somebody stay with them at night to help Dad as he needed it, but now they don't need Dad anymore. So they're really doing well.
And that's such a different scenario than if the thing with many surgeons, I'm not going to generalize and say all, but the thing with many surgeons and with many oncologists is that they have all kinds of things in their tool bag. Right. And they'll pull, the first one that's going to come out is the one that's most known to be effective for whatever's going on. Mm-hmm. And then if that doesn't work, well, I got this other thing in here. Mm-hmm. And it's like Mary Poppins' bag. There's always another thing in there if you're willing to continue to take the options that they're offering you. And some people will absolutely, you can be giving me chemo while I'm in my coffin, but I want everything as much as I can. Other people say, wait a minute, just how much is in that bag? And what is that going to do to my ability to live my life and see people? And, if you're young or if you're old, once you go down that road, you are pretty much at least feeling like you're living at wherever it is you're getting treatment, because anything that you do can have a consequence. Something else. Something else could go wrong. It's like, there's always a possibility of something else. And especially when you're older and you have less resiliency, physical resiliency, I'm not talking about mental, but physical resiliency, you don't have much, poking that you can take before you are going to, fall down. Right. And so it's like a very small wedge, a very small line between I feel good and I can go putter in my garden and I'm just laying in my bed and I can't move.
And we don't know on the onset when they say we can give you this. We don't know if that's going to make you better or not. We don't know if it's going to, what the side effects. There's a lot we don't know. But I know with my friend Glenda, who died in September, she had stage 4 cancer for 6 years and went through lots of different treatments. But towards the end, she said, I'm tired of watching life happen outside my window.
Mm-hmm.
And she was a very active, engaged person. And we met with her oncologist, and he said, I have one more thing. And so, meanwhile, I'm on my phone seeing what the side effects of that were. And she said, how much might that help me? What percentage would you give that it might help? And he said 15%, 15. And that was a no. That was the end. And the next week she was signed up with hospice. And that was, she said that was the best decision she made, and had a wonderful few months on hospice before she died.
And that's so true. So that question that she asked was good. Like, how much is this going to help? Another question that's really helpful is to say, how many extra days might I get from this? Mm-hmm. And there's studies that will show that with traditional treatment, you can survive this long. With this one, you can survive this long. So you can, give a reasonable range. And sometimes I say to patients, well, if you take that treatment, that'll give you an extra week. Mm-hmm. And they'll kind of look at me like, a week.
Yeah. Really?
It's a week. Like we have, that's why they do research. It's like it's a week or it's a month. And so then what you have to decide when you're looking at that is to say, well, so on one hand, it's going to cost me going to the cancer center, I don't know, I'm making this up, every day, and I'm not going to be able to eat, any milk products, so I can't have any ice cream, and I can't go to Target anymore, versus an extra month. And some people look at that and say, I'm not giving up ice cream in Target for a month.
Right.
And other people look at that and say, okay, yeah, that's a good, I can live with that. For an extra month, yes, I'll do that. Mm-hmm. So, another good question for our listeners is, so how many days or how many weeks? Like we think, I've seen patients think, so how many years is this going to give me? And you're like, oh, honey, it's not years. Mm-hmm. We're talking weeks, maybe. Mm-hmm. And that's real hard to get your head around.
Mm-hmm. Well, and when you and I were talking initially about Dad, he was very confused and not able to engage well at all. And it turned out that he had a UTI.
Oh, my goodness.
And we know that. We know that that's often a problem with older patients, that they get a UTI. They may not have symptoms, but it causes great confusion. And as soon as that was treated, he came back. And we just like, oh, my goodness, I can't believe it. But I think for me, what we were missing was what palliative care would provide, and that would be a team of people who looks at the whole person, because it's so fragmented right now, especially if there are different issues going on with a person's life, to be able to have somebody that can come in and see the big picture and say, oh, yeah, those are symptoms of the UTI. Let's get some antibiotics started and see if that doesn't clear up.
So we referred you to palliative care. Did you go to that appointment with your dad?
We did. And they said they would refer us to palliative care, that they didn't have a palliative care team.
Who's they?
Dr.
At the cancer center?
Orwig. Mm-hmm.
Oh, you mean outpatient? So you went and saw the supportive care or palliative care team at the cancer center. So what was that? So what was that appointment like? So our listeners can have a sense of, well, if you go to talk to these people, what happens?
Well, we went to talk to them, and my parents and I really enjoyed talking to him, and he laid out what would happen, what the options are if you choose not to have treatment, and that was really the direction we were all going. And but he did say, and we were hoping to get set up with palliative care because that's kind of what I thought would happen. But he said that we would talk to the social worker who could refer us to a palliative care team.
So you mean outpatient? Is
right.
What you're saying?
Yeah, because Dad was not inpatient. Yeah.
Right. So the other option, just for our listeners, is that we think, well, I don't want any of that hospice stuff, but I'll do palliative care. And a lot of, when I worked in hospice, Connie, it was the same team. So we had people who said, what did we call it? We called it transitional care. So people who said, I don't want that hospice, so we would admit them to transitional care, which was really, home care, but it was by the hospice nurses. And then over time we could chat with them about, so why is it that you don't want hospice care? What is it, just the name that you don't like? Or they'd have trouble getting their medications, and we could say to them, well, if you were on the hospice benefit, hospice would pay for all of those medicines and deliver them. So we would have to do like some teaching with people, because the word hospice was one where people said, I don't know, hospice is where people die. It's like, well, and then you'd have to have the conversation. Well, this is pretty, very, very serious illness that you do have. So one thing, in terms of for your dad or for any of our listeners thinking about it, you don't have to have an outpatient palliative care team. You could say, can I have a hospice referral? And the criteria is that there's a less than 6-month prognosis. Thing is, nobody really knows that. It's a very old criteria, and and with your dad, he could have a year, or he could fall and break something and have far less, but we don't know. So, you can get all of the same benefits that you would get from palliative, like an outpatient palliative program, in a hospice program, plus more, because they pay for the medicine and they deliver any kind of goods that you need. The nurse comes right to the house. So there's a lot of benefits from electing that hospice benefit. And if you last, I want to put it that way, but if, you go past the 6 months, nobody says, oh, you're out of here. It's like, hey, great, good for you. They just recertify you for another 6 months. So, and it's such a wonderful
hospice
program.
Care is palliative care.
Absolutely.
So it just makes perfect. It's a word thing, and people. It was hard for people, and around us to take. I was ready for hospice care long before anybody else. And they're still not doing that. But the reason that I thought it would be helpful was for that exactly. They would not have to go to all these appointments. There would be people that could come to them and not spend the night, just stay with them and make assessments and be able to make recommendations and deliver medications.
Yeah. And I'll tell you, given how the environment is in terms of if he is on opioids or needs opioids, there's a major thing with, my patients when I was working in supportive care, it'd be like, I live out in a rural area and you ordered me, 2 a day, Oxy or whatever, which is 60 pills a month, but they only had 24. And if I get those 24, they're going to void the rest of my prescription. Or pharmacies only receive X number of pills a month. So if it's at the end of the month and they're out of the drugs, well, then you've got to go, well, now let me find another pharmacy. Then you have to start looking around and say, well, which pharmacy has the medicine that I need? Where with hospice, you don't have to deal with any of that.
Sure. Yeah, I think it makes perfect sense, and they see the whole person and the family. It's not just the patient.
Right.
So the value is, like I said with Glenda, when she did it, when she made the decision to go on, she was still active. We were going out to lunch, we were spending a lot of time together, but she had that support she needed, and it was perfect until the end. It was exactly what was right for her.
Well, so, I really encourage, our listeners to kind of put away, or start to put away that feeling like, oh, hospice, it's not a good thing. Hospice is a good thing. You might not like what it's called, but it certainly is so supportive for you and your family, especially if and when you get to that point where you're not able on your own to go and, get to the doctor and do a whole lot of appointments. And then you're paying, a copay or whatever for every one of those.
Right.
Chronic illness is expensive and it takes up all your time.
Right. No, and my family, they've got lots of babies coming, and they're third generation, and they are and a fourth generation, and they have lots to look forward to. So that's where they need to spend the time. I'm also a conscious dying coach, and so I spent several hours interviewing my parents about what was important to them to have finished for the end of their life. And that was such a valuable experience for me, and something I treasure, to be able to have a conversation that's often difficult for family members to talk about, but how do they want to be cared for? How do they want their body taken care of at end of life? And to know those things, and to know that my parents have done a tremendous job of taking care of the steps that they need to take to be where they want to be at end of life. So they can just be, and so did my friend Glenda. We did the same thing, so that they don't have to worry about, I've got to get this stuff done before I leave. They can just be joyful in their moments here.
So, now, what was the term that you just used? Conscious dying?
Conscious dying, yes. It's a conscious dying. So
can you talk a little bit about that?
Sure. It's really it's through a group called the Conscious Dying Institute, and it is a program in which we learn how to help people at end of life. And a lot of this is around looking at the different components of your life: spiritual, physical, mental, emotional, and physical. And there are a series of questions that are excellent that guide your client through the opportunities to look at what's important to them, and maybe make a checklist of what needs to be done before end of life. And you do it from the perspective as if you have 3 months left to live. And I've done it myself. And so I could list the things that I want to be sure I have taken care of before I leave, so my children will not have a mess to deal with. On my departure, I want me to leave with them liking me.
I recently moved out of the house that, I'd raised the kids in, and I was like going through things, and I thought, if I keep all this crap, the kids are really going to be mad at me, because, it's like, how that is. It's like, I know why I saved it, but I thought, will this mean anything to them? And even things I thought that would mean something to them didn't mean anything to them. And I think that we need to, our generation needs to start thinking about that. It's like, how much crap, and I mean that in the most loving way, do you want to leave behind for other people to, to sift through?
Yes, and my parents are models for that. They've done such a great job, and all of their papers are in order in a file, and we all know where it is. And they have done a super job of preparing, and they're my models for that. They truly are.
Wow.
Yeah.
Well,
there is a book that I know about, Marianne, that I thought I'd share with your listeners.
Yeah.
I love the title. It's I'll Be Right There. It's a guidebook for adults caring for their aging parents. And it is a huge manual of everything you would need to know for caring for aging parents. A lot of us get to that point without having a manual and not knowing exactly what to do. So it's a great title, I'll Be Right There, by Fern Pessin, Pessin, and I highly recommend it.
Great. I'll put that in the resources along with your interview.
Okay.
And Connie Baker is also on our board of directors at Everyone Dies, so I'll make that disclosure. And so we appreciate everything that you do to help us in terms of our work here at Everyone Dies. And I'm so glad that you took time out of your day to talk with us about these issues. And I'm so glad Dad is doing well.
Thank you. He is doing well, and I always enjoy talking with you, Marianne.
Thank you.
Thank you, Connie. And here's our episode that originally aired in April of 2020, where we discuss concept of palliative care, how it integrates with medical care, and the differences between palliative and hospice care. Enjoy.
This podcast does not provide medical advice. Please listen to the complete disclosure at the end of the recording.
Welcome to Everyone Dies. I'm Marianne Matzo.
And I'm Charlie Navarrete.
And welcome to our podcast, where we talk about things that most people will go to the other side of the room rather than talk with you about. I've worked as a nurse for over 40 years and as a nurse practitioner since 1985. And I've done a lot of travel for work and privately. And often when I'm in an airport or if I'm sitting on an airplane, of course, the person next to you says, "So, what do you do?" And I usually say, "Well, I'm a nurse." And, "Oh, what kind of nurse? What kind of nursing do you do?" And if I say oncology or palliative care, generally people know what oncology is. But palliative care, "Oh, what's that?" So when I explain to them what that is, they'll say, "Oh, then you're going to love this story." And then they proceed to tell me about the people in their family who've died. Or I had one woman once say to me, "Well, you'll be interested in this story." She said, "I pulled the plug on my mother." And I thought to myself, all right, I'm going to have to jump into this one. "Well, what do you mean you pulled the plug on your mother?" "Well, I shut off her respirator, ventilator." And I remember looking at this lady and saying, "Did you really shut off her ventilator, or did you do what she had asked you to do?" And she stopped and she looked at me and she said, "Well, I did what she wanted me to do. She wanted, if in certain circumstances, she didn't want to live on the respirator and she wanted it to be shut off." I said, "So really what you did is you gave her a tremendous gift of love because you did something that was hard for you to do, but something that she wanted and that she had written down in her advance directive and had talked with you about and said, I don't want to live like this. And if I'm in this situation and I can't make decisions for myself, here's what I want you to do." And you did it, even though that was really hard and it was really painful and you knew that your mom was going to die. And this woman, had tears in her eyes and she said, "Well, yeah, I guess." She says, "I never really thought about it that way." I said, "You gave her a gift of love. You didn't kill her. You didn't shut off the respirator. You did for her what she asked you to do." And the woman just had a totally different look on her face. And you could tell that gave her something different to think about. And I think with dying and death, there's very few people that we can go to and say, "Let me tell you what happened." And I think that it's important for us to have somebody to tell, somebody to ask questions. And that's why Charlie and I are here. That's why we're doing this podcast, is to give you the opportunity to ask questions and tell your stories and give us an opportunity to give you some different perspectives on this whole phase of life called the end of life.
Yes, because many times people it's a taboo subject and people are just not comfortable discussing it or will make jokes about it. You mentioned advanced care directives, which is one of the things I do. I help people fill out different documents. And as soon as, and again, the same situation, what do you do? And I mentioned this, immediately someone has a story related to death and dying. But it's what you were saying. It's usually some negative spin, or they have some emotion about it without thinking if that's what somebody wanted and you help them to fulfill, their wish the way they want to die. It's something very positive. And yeah, it's that. It's just something very positive. You've done something good for somebody else.
It's really a very difficult decision and very difficult gift to give people. But, what really in life is particularly easy? Even giving birth is not easy.
Right.
So, being human, being alive, it's tough work. And the end of life can be tough work too, but it can be a very, very gratifying experience to be with somebody on that journey.
Yes. And it will bring up a lot of emotions in many people, especially if there's some unresolved feeling or emotion with the person who has died. There's just a variety of situations, of reactions that can arise.
Oh, absolutely. And also puts a tremendous stress and strain on families as they're going through that process. It can bring you closer with your family, but it can also sometimes cause what seems like irreparable harm. Yeah. As in going through those decisions.
Yeah, and then that's why it's always important to prepare. For the person who is dying and needs that advanced directive, their healthcare proxy, that details, which details their wishes. That then needs to be discussed with the person who is the actual proxy, and if there are other family members involved, everyone just should be made aware of it in advance, just so everyone is prepared. Because the last thing you want at someone's deathbed is suddenly emotions erupt and no, let's try something different, let's go in a new direction, which is not what the person who is dying wanted. So right. Just need to put everything out there on the table in advance.
Thus the name Advanced Directives.
Absolutely.
Ba-da-da boom. So, Charlie, do you want to tell the audience how you got interested in this, or why you're being forced to record this with me?
No, nothing's being forced here. I worked at a law office for many, many years, for about 16 years, doing research on products that could contain asbestos. Eventually, I was asked to interview clients who were dying from mesothelioma. It's a cancer that people have after being exposed to asbestos. Because these clients were dying before we could get, before we could obtain their information of how they were exposed. And from the start, the very first client that I interviewed, and this gentleman was in an ICU, in an oxygen tent, not in good shape. So it took about a day and a half to interview him. He really was, at the end of his life. And with that, at one point he said that at one point he asked me if he needed a will, because it was only himself and his wife. They had a house, a car, and that was it. So really nothing was needed, right? And I explained to him that no, the state would investigate to make sure that, all the paperwork was in order, that she indeed was his wife, was that it would just be easier just to have a will, because then she was going to have to go through the process of not only dealing with lawyers, but then paying for additional lawyers. And as time went on, I kept interviewing more and more people. People were not sure of their rights. People asked a lot of questions about how to avoid being in pain. People wanted to know what they could do, how they could die. Did the doctor have to listen to them? Just a lot of stuff that people were just basically unaware of. So I became more and more educated on all this. And eventually, when I left the law office, the spouses of former clients would contact me and say, hey, my friend is going through something similar. Would you mind talking with them? So in the end, that's what I wound up doing, just type of consulting work for end-of-life issues.
That's incredible. Are there a lot of people out there that do that kind of work?
Just that on its own, I haven't encountered many. I've encountered people, especially now, who are, there's a category now of doula, an end-of-life doula. Mm-hmm. So I've encountered more and more people who do that type of work, and in that work are advanced care directives. I've encountered nurses and doctors who will sit down with their patients to discuss that. But interestingly, even doctors and nurses, some are still reluctant to sit down and put everything out there, afraid that they'll accept. They're still uncomfortable putting everything out and giving people all the information up front for fear of upsetting someone. To me, it sounds a bit old-fashioned. I know when, in the past, you just would not discuss, many times doctors would not discuss death with their patient. But this is the 21st century, and I'm just surprised to still run across, medical professionals who either are uncomfortable or reluctant to sit a client down and just spell out everything to the client,
Well, when you read the studies that, explore why is it that healthcare practitioners don't want to talk with their patients about death, is what you find is a couple of things. One, like you said, they're not comfortable with the topic. As Americans, we are really a death-denying culture. We think all we have to do is say we're not going to die, and we're not going to die. But as my dad would say, there's two things you have to do is pay taxes and die. And there's not everybody who pays taxes, but everybody dies. Yep. The second thing the literature shows us is that healthcare practitioners believe that the patients want them to have this attitude or this view of hope. And I believe that hope we give that absolutely. Even if we're talking to people about the end of life, we still have hope. What we're hoping for may change.
Right.
You might say, I hope to live long enough to see my now 3-year-old daughter get married. And over a course of a terminal illness, what you're hoping for can change. Maybe you then hope I get to see her go to first grade. Or I hope I get to see her learn how to ride a bike. Or, what you hope for continues to change depending on your circumstances, right?
Right.
So hope we can always give people. But what the literature talks about is that the thought that healthcare practitioners believe that what their patients want is for them to say, well, yes, I can cure you. I always have another drug. I always have another surgery. I always have another something that I can do and to try to cure you. But the reality of the situation is that we're mortal. We might be able to slow down a disease for a little bit, if it's a terminal, life-threatening illness, but we're never going to be able to give somebody the opportunity to live forever because we're not built that way. We're built as mortals. And so, yes, we're all going to die. And it's a matter of how you're going to die. And you never know, of course, the circumstances of it. But let's say you have end-stage cancer, or you have an end-stage mesothelioma.
Mesothelioma, yeah.
Mesothelioma. Like you have experience with. Well, then it's like, well, let's talk about your symptom management. Let's talk about your goals. Let's talk about your beliefs. And it's not about the cure at that point. It's about an honest and good conversation so that the patient and their family can prepare for what's going to happen. And we all believe, oh, well, we're never going to die, so we don't need an advance directive, right?
Right. Yeah, people think that they're, as you mentioned before, well, this is not, I don't, in some peripheral way, think, okay, well, we all have to die without really, well, just basically preparing for it. And it is a preparation. It's just, what you want for yourself. If there's something you want to leave. I mean, with a lot of the people I encountered, just basically wanted the nuts and bolts. They were not really that interested in looking at anything philosophical or anything religious. They just wanted to make sure, the biggest thing, nobody wanted to be in pain. And a lot of people were not aware of pain management. And when I mentioned that morphine is a part of pain management, because a lot of these people were older, still had this image of morphine as something bad, and you'll become a morphine addict. And I had to explain to them that it's not that way anymore, that morphine is just part of a treatment. So people had difficulty adjusting that and were fearful of becoming addicts, like I said. And I would point out sometimes, well, again, this will be controlled by your nurse, by the doctor. And would you rather, if you're afraid of becoming an addict, are you going just to focus on that? And if you're afraid of becoming an addict, what about the pain? I mean, are you going to not take pain medication because you're afraid you'll become an addict, so you'd rather just stay in pain or deal with the pain?
Well, and some people will not want to have the pain medication for other reasons. They'll say, certain religions, for example, believe that you should suffer before you die so that you can have a pure entry into the next life. And so they'll resist pain medication for that reason. Oh. Some people think that they need to be punished. And so if they suffer with pain in this life, they'll, be able to go to heaven, and not have to suffer in the next life. So there's lots of different reasons and views of pain medication. And at some point we should do, just focus on pain medication and what you can expect what you can ask for in terms of that kind of care at the end of life.
Yeah, exactly. I mean, there's no reason for anyone to die in pain anymore.
No, I always would tell my patients, you don't get extra points for being in pain. So what are you eating today?
Well, we had talked about chocolate cheesecake.
Death by chocolate cheesecake.
Death by chocolate cheesecake. Which, just, was not an easy chore because I expected just plain, simple chocolate cheesecake. Mm-hmm. So just going around, well, I didn't go through all of town, but just... So with the help of the internet...
I can see you in your trench coat going bakery to bakery in New York City saying, I need death by chocolate.
Well, what I did finally... I mean, there were places that said advertised chocolate cheesecake. So I dropped by, but first, the first place, it wasn't a pure chocolate cheesecake. When I say a pure chocolate cheesecake, it's simply a cheesecake of chocolate, made of chocolate. That's it. But the first place I went to had a chocolate mousse cheesecake. Well, yeah, but you see, that's not strictly a pure cheesecake. It's
we're going for purity here?
Well, it's you said a chocolate cheesecake, and yes.
We have standards.
Absolutely. So it was a chocolate mousse cheesecake, which, begged the question, is it chocolate mousse wrapped around a cheesecake? Because, mousse is made up of, well, now, come on. So a mousse is made up of...
Legs, tails.
Legs, yes, legs, tails. And if it's a chocolate mouse, it's made of something else. But, yeah,
Mickey's in quarantine.
Ugh. So, yeah, I mean, a mousse is, is made up of light stuff. Cream and eggs, right? Cream and eggs. Well, let's just say cream and eggs. But, I mean, the cheesecake has what? Like 2 pounds of cream cheese. So I didn't really think it was an authentic, simple chocolate cheesecake. So I went to another place. Well, there...
you do suffer for your art,
I
Charlie.
know. Yes. Well, at the second place, I found a variety of chocolate cheesecakes. I mean, they just had different ingredients baked into them. One had cherries. And several with other different ingredients just weren't even chocolate colored because all the ingredients. And it said, so I kept asking for, do you just make a simple chocolate cheesecake? Finally, I was asked to leave. So I thought, well, no. So I guess this is not going to happen. So I mentioned this to a friend of mine, and do you remember that scene in Moonlight where Cher looks at Nicolas Cage and slaps him across his head and says, "Snap out of it."
Yeah.
Yes. So my friend didn't really hit me across the head, but just looked at me like I was an idiot and said, "Snap out of it." And pointed me.
If you were closer, yeah. I would be tempted to go all the way and slap you. Yeah.
Oh dear. Okay. So she pointed out this old Italian bakery in the East Village in New York. It's been around over 100 years.
What's the name of it?
Venero's.
Ah.
And I've been there several times, and they make a cheesecake, a New York-style cheesecake. It is, oh dear, it just melts in your mouth. It's just, well, Venero's, yes, they have a, quote, chocolate cheesecake, but again, it's a chocolate mousse cheesecake. So, I did not have time.
So, that's our show.
So, so I just looked it up. I have not been there yet. So I will report back next time. I'm going to break down and actually try this only because it's from Veneros. And they make outstanding New York cheesecake. So this thing is supposed to be a New York style chocolate mousse cheesecake. And I will report back. I will go down there and try this one.
We are all waiting with bated breath.
Very good.
But for those of you who are not in New York, we will post a Death by Chocolate cheesecake recipe, and y'all can let us know how that goes. So you got your scotch, you got your cheesecake, you ready to rock and roll?
Yes, scotch. You know what? I think maybe just because with chocolate, maybe whiskey or bourbon would be flow better.
I think you should do like a double-blind experiment and then just let us know how that turns out.
Okay, if I have to.
I know. So we were going to talk today about palliative care. And Charlie, in 15 words or less, what's palliative care?
Well, actually, for me, the first thing I would wonder, are you also going to discuss hospice care? Because when a lot of times...
Maybe.
Oh, please.
So you're thinking hospice and palliative care are the same thing?
Oh, me personally, no. But only because again, just working with different people with mesothelioma, I got to know the difference. But for me, for palliative care, I'm sorry, 15 words or less?
Well, you've already gone over that, but go ahead.
Basically, with palliative care, is someone is in pain, and it's just in palliative care, it's just a way to alleviate the pain.
So palliative care is all about pain.
Is making people comfortable. It doesn't have to be necessarily pain, but just to make people comfortable.
Okay. So can I be teachy for 30 seconds and give the actual real definition of palliative care?
There's nothing teachy about it. I think we all need to be, have the right information. So please.
Okay. So the World Health Organization defines palliative care as, and I'm going to read it, an approach which improves the quality of life of patients and their families facing life-threatening illness through the prevention, assessment, and treatment of pain and other physical, psychosocial, and spiritual problems.
Yeah, it just about covers it.
I'm so glad you approve of the World Health Organization.
Ooh.
So
yes, and actually, it's true. I did not mention exactly that it does have to do also with people who are dying. So yes.
Well, so what the World Health Organization says is facing life-threatening illness.
Yes.
So I'd like to, as a sort of point of information and a way to discuss palliative care, tell you about something that happened with me, probably 7-8 years ago now.
Mm-hmm.
I was working a full-time job and probably about 3 or 4 other part-time jobs because that's how I tended to live my life professionally. There was a lot going on and a lot to do. And my best friend had just dropped dead suddenly in July of that year. And right not long after that, my sister called me and said, she says, I have liver cancer. I'm like, what? This is somebody who never drank. And that'll be a whole other story we can talk about at some point. And I went out to Michigan to see her. And it was really a profound experience to be with her and realize when I left, I would never see her again. So saying goodbye to her was just heartbreaking. And so that was like in October. So I'd had these two incredible losses and working a lot and young kids. And I was having this cough, this really dry cough that just wasn't going away. And I was just feeling worse and worse and worse and worse. And finally, right around Thanksgiving, the kids had left to go be with their dad for Thanksgiving. And I couldn't stand the cough anymore. And I went to urgent care center, and they said, well, it looks like you have pneumonia. You really should go to the ER. So I went to the ER, and they did an x-ray, and they said, you have a pneumonia, and, we can give you antibiotics and send you home. Or if you want, you can stay here. We'll give you IV antibiotics. You'd probably feel better a lot quicker. And I thought, well, it's the day before Thanksgiving. Kids are in Florida. I didn't want to make a turkey for anybody anyway, so I'll just stay in the hospital and let them give me the antibiotics. And the next thing that I remember after that decision, it was the day after Christmas.
Yeah.
And I woke up sort of in the ICU, and I had a trach, and I was on a ventilator, and I had tubes just everywhere. I was on a feeding tube, and I was like looking around thinking, what the hell has happened? And people started telling me what had happened. I guess I had just tanked and had high fevers, and my breathing was compromised. I had adult respiratory distress syndrome, and that alone has a very high mortality rate. People die, young, healthy people will die from that. And I woke up, and my ex-husband was there. It was like, well, the kids told me what I said, and it wasn't really very nice, but I don't remember saying it, so I don't have to take, the bullet for that one. But it was like, what the F are you doing here? But like I said, I was in a drug-induced coma, so I'm not responsible. Mm-hmm. Yes. And the whole thing was like, I'd been in the ICU for over a month, and
you were out. I'm sorry, were you out that whole time? Unconscious?
Yeah, they had me in a. I guess I had crashed, and they had to intubate me, and they put me in a drug-induced coma, and I had really high temps, and they even, I guess, did a brain scan to see if I had any brain activity, and of course, when I was able to talk, I was like, well, so was there any? And but as the story unfolded, as people told me what was going on, and as I then started going through rehab, I was out of work for a long time, and I had to learn to walk again, and it was just a mess. What was helpful and what they were doing was they were doing palliative care. Now, was I dying? Well, they didn't really know. But in the event that I wasn't dying or that I didn't die, they wanted, my body to still be whole for what was going to, whatever it is that was going to come next. And so the physical therapist would come in. I wasn't able to pass a swallowing study, so I had to, have rehab from that point of view. What they were doing in terms of palliative care is they were managing my symptoms. They were providing comfort for me and my family. Right. The kids were scared. I was just, the whole thing was really unbelievable for me. But what's important about palliative care is that it's not restricted for people with terminal diseases. You don't have to be dying to get palliative care. So palliative care really starts at the time of a diagnosis of any disease that potentially could be life-threatening or life-limiting. And that would include heart disease. That would include diabetes. All of those things can limit, cut down on the amount of years that we have. It can be cancer. It can be anything that could potentially result in our death. And so while they're trying to cure, they're also palliating the symptoms, managing pain, managing anxiety, managing physical changes. All of those are aspects that are important to palliative care. And palliative care also looks at not only what does that patient need, but also what does their family need. And so supporting the family through that. Also, the thing with palliative care is that doesn't belong to one discipline. It's not just nurses or it's not just physicians. It's really an interdisciplinary team that wants to relieve that suffering, improve quality of life. One of the palliative care practitioners for me would come in and do Reiki treatment, which is like an energy healing kind of thing. And what it did for me is it made me feel much more calm in this situation of an ICU where, I'm on a ventilator and they tied down my hands so that, I didn't reflexively pull out my trach. But those moments in between the medicine to make you go to sleep, you're aware of it. You're aware that your hands are tied down, that you can't move, that you can't roll over, that you can't do anything on your own. And that's really difficult, and I would say even causes suffering. If you're somebody like me who's very independent, not being able to move was horrid. So palliative care, if we want to remember, is offered simultaneously with all other appropriate medical treatment. It's not an either-or situation. You don't have to pick. They come together kind of in a package. So the goals really are to have people have a better quality of life, make sure that people are functioning as well as they possibly can in the situation that they're in, will help with decision making. I had an advance directive, and I'd had two. I had one when I was married, and that gave him the durable power of attorney. But after we were no longer married, I'd done another one. And apparently it wasn't easily found. And so he used one, and he did a great job as being an advocate. And I shouldn't have said that. What I said when I woke up and saw him there, because he really did a phenomenal job of advocating for me and being there and taking care of the kids and keeping them calm. I mean, it was incredible what he did. So palliative care helps with that decision making and gives opportunity for personal growth, in terms of the chaplain who comes in, social work who comes in, all the different disciplines who are involved in getting you through that potentially life-threatening illness, and or supporting the family if you don't make it all the way through.
And then, but also too, you're speaking, what happens specifically in a hospital, but people also have, palliative care at home. And what you were saying about like an, interdisciplinary team, from what I've experienced, actually with my former father-in-law, he wound up coming up from Florida and staying, at the co-op, and my ex, took very good care of him. But everything there was in house. There would be, a visiting nurse, but there were, people there, friends, relatives who would come in and just help with help with all of that. So it wasn't, because a lot of times people just prefer to be at home, in very familiar surroundings. That's not always possible. But
so was he receiving hospice care or palliative care?
At first, it was palliative care.
Mm-hmm.
And eventually, his health did deteriorate, and he died of cancer. No, but at first it was palliative care. And that lasted, months. It was close to a year, and then his health started to really deteriorate quickly.
Mm-hmm. So you were asking before about, so what's the difference between hospice and palliative care?
Mm-hmm.
So what I want you to think about is that palliative care starts at the time of diagnosis of a life-threatening or life-limiting illness, right?
Right.
And that goes on. And how much palliative care you need and receive and how much curative care you need and receive can change over time, just like you're talking about with your father-in-law, is that initially, he was in one state of physical health,
right,
and that changed over time.
Yes.
And so his need for more palliative care increased, and there was less of that medical involvement for potential cure or management,
exactly,
right?
Exactly.
So that balance switches and changes. And because we're all mortal, because everyone dies, at some point in that illness or in his life trajectory, he's going to get to a point where it's all palliative care. And that brings us to the hospice benefit. So hospice is a model of care started in England.
Uh-huh.
How we do it in the United States is a little different in that it's a benefit. So like if you were to pull out your health insurance and look under the heading that said hospice, it would tell you, here's what you get for your hospice benefit. And there are rules about it. So the rule is you have to have a physician's order.
Yeah.
And that's a problem, and I'll tell you about that in a minute. And you have to have a less than a 6-month prognosis,
right,
meaning
right.
In the professional opinion of your healthcare practitioner, you are going to die in 6 months. Well, that's a problem because I don't have a crystal ball. I have ways that I can look at a patient and assess a patient and see what they're able to do and, how well they're able to take care of themselves. And I can make a guesstimate, but I do not get any messages from God or anybody else saying, it's that person there, they have less than 6 months. So going back to, we were talking before about, healthcare practitioners want to be the people who can say, I'll cure you. How do they then say, but you're going to die within 6 months? It goes against their grain.
Right.
So it's a very difficult thing to say to your patient, I really think it's time for hospice. I wouldn't be surprised if you were going to be dead in the next 6 months. That's a conversation that really doesn't occur. In our country, hospice care, that hospice order happens very late. People sometimes spend only a couple of days on hospice. When I worked in hospice, I had a colleague who was doing the hospice admission, and the patient died during the hospice admission. And it was like, that was a really late referral. Yeah. There's so much that hospice can offer, and it's really just a shame that it comes so late in our country. But it is because one of the barriers to getting the care is that the physician needs to prescribe it. Mm-hmm. And the physicians or the healthcare practitioners really don't like to have that conversation with people. They don't think the patients are going to trust them anymore. It's like, hey, doc, I'm coming to see you for you to treat me and cure me. And you're saying I need hospice? What kind of doctor are you? So there's a problem. I saw a cartoon once where there's a physician and a patient talking, and there's like a bubble over their head, and the physician saying, I don't know how to tell him that he needs hospice. And the bubble over the patient's head says, I wonder if he's going to tell me that I need hospice. Because people think about it. People know about hospice. Many people now have had somebody that they've loved who's received hospice care and hospice support. So to say, well, here's how this benefit works. It's going to give a lot of services for you and for your family and a lot of support. And I've had patients say, well, it's the benefit is for 6 months. Well, what if I survive for longer than 6 months? It's like, well, then, we celebrate and we recertify you for hospice and we do it again. Nobody says, oh, you survived too long, so you don't get your hospice benefit anymore. It's okay to go over. That's great.
But I mean, why? So why do physicians and nurses also still have a problem discussing this with their patients? It's a medical procedure. It's a procedure. So,
well, it's not a procedure because a procedure implies I'm going to stick this tubing somewhere and do something.
Yeah.
So it's not a procedure. It's a benefit. It's a service. But the sort of conventional wisdom or how people tend to look at it is, you're giving up on me. You can't cure me. You're giving up on me. And so you're tossing me over to those other people. Where when I worked in a palliative care clinic at our cancer center, what I would say to people at the very first meeting, they already have a cancer diagnosis, they're having symptom management issues, is that I would say to them, I'm going to be with you on this journey. So no matter what comes your way, you can come here to our clinic and we will help you. Now, I don't say I'm going to cure you because I don't have a way to do that. But I can make a promise that I can be on the journey with them and that I can support them and that I can listen to them. I can do all of that. I can promise that and keep that promise. But can I promise to cure somebody? No, I can't promise that.
So on that journey, how do family members or loved ones, and today family can be described in so many different ways.
Right.
So how do, quote, family deal with this? Because some people just maybe naturally have an empathetic gene and others don't.
Well, so are you asking how do they deal with palliative care or how do they deal with hospice?
Well, actually both. Have you come across places where, people are trained or to do this, or will caregivers, just talk to doctors or find support groups online to go through this? Because this, as you say, this can last a long time, depending on the condition of the person. It could be something 24 hours or just simply checking in on someone.
Well, I think that, in social policy, any kind of social policy has really made changes through what's called grassroots. When the public says, hey, we need this. This is something that's important. This makes a difference. It then puts that pressure on policymakers and on practitioners to build what the patients are requiring, what they need. And so, for example, at our cancer center, we had a huge, wonderful cancer center, but there was no palliative care service to manage all of the symptoms that come with having cancer and having cancer treatment and having surgery and chemotherapy. And so, with the wisdom of the director of the cancer center, is like with, advocacy from the clinicians, it's like, we need to have this place, this clinic where the oncologist can send people And we can manage those things because there's no way that the oncologist has time to address pain and the depression and the sexual health issues and, advanced directives and everything that kind of goes with it on top of managing the cancer. There's just not enough time in that visit.
Yeah.
And expertise. I mean, palliative care is its own specialty. It's, there's a lot of extra education that goes into being a palliative care practitioner. Like, I'm certified as an advanced practice palliative care practitioner. Physicians can be certified palliative care physicians. It's not just, hey, I have a barn, let's have a palliative care clinic. So, so it's an advanced training and education. So the systems where you're receiving care, you need to say, well, I want to consult with the palliative care. Where's palliative care? Now, if you're in a VA hospital, for example, the VA has absolutely embraced the palliative care model, and just about all of their hospitals, if not all of the hospitals, have a palliative care team, and many of them have an actual palliative care unit. You go into the community hospitals, though, it's hit or miss whether or not they'll have a palliative care team who can help manage your symptoms. Like the hospital I was in, like I said, I received palliative care. There was a palliative care practitioner who followed and supported me through that, life-threatening illness. Not every hospital will have that. But if enough of the public goes to, their hospital and says, okay, my mom's here, she has this life-threatening illness, I want to talk to the palliative care team. And they say, well, we don't have one. Well, there's a great opportunity. You write a letter to the president of the hospital, the board, and say, this is an important aspect of care for people who have life-threatening, life-limiting illnesses. And I've had people who say, well, you mean they don't have that? There's the assumption that that's there and that's part of the healthcare package.
Right.
And people are in fact kind of stunned when they find out, well, no, that's hit or miss. It depends on your geography. Sean Morrison in New York City does, I don't know how many, every couple of years, he does a report card on palliative care in each state. And he bases it on, I'd have to look to tell you exactly, but, like how many palliative care units and practitioners and, the access to service, right?
Right.
And, certain states get A's. And when I first moved to Oklahoma, we had an F.
Oh.
And, and we moved up to a D, but we moved up, right? We did some work to get so that there were more services available for people, but we're not an A. And so you can actually look that up online, and we can put a link in for you so you can look up your state and see what grade is your state getting in palliative care in terms of access. So there's insurance, there's the hospice insurance that's part of every if you have healthcare insurance, it's a part of every insurance package.
But is there a limit on that with the insurance?
Well, what they say is that it's for somebody who has a less than a 6-month prognosis. So meaning that, would you be surprised if someone were to die in 6 months? And so that's what they are kind of budgeting for, is that within the next 6 months, you're going to die. And that 6 months really came out of a cancer diagnosis. But palliative care is used for any kind of life-limiting. So it could be for heart disease or diabetes or Alzheimer's disease. So it's not just, a cancer diagnosis, although that's how the model was developed. That's where the 6 months came from.
I see.
But like I said, if you get to that 6-month point and you're still alive, they don't throw you out of hospice.
Right, of course not. Yeah.
So they budget for 6 months. But like I said, average time in hospice in our country is a couple of weeks. So the majority of people are not getting their full hospice benefit because they come into it way too late. And it's generally related to lack of communication with their healthcare practitioner because, like I said, the healthcare practitioner has to write the order.
And I also, from what I've seen from different clients, is that there's no clear, yes, there is a distinction between palliative care and hospice, but sometimes in an actual real life situation, that line gets blurry, and palliative care has crossed into hospice without a clear definition. Have you encountered that?
Well, yes, and that's generally because either the physician, the primary healthcare provider says, oh, no, they're not ready for hospice yet, and they won't sign the order. Or the family and the patient say, oh, no, I'm not ready for hospice. I don't want that yet. So when I was living in New Hampshire and working for a home care agency, they had something that they called transitional care, which was regular home care provided by the hospice nurses. Meaning, hey, you really should be on hospice care, but you're refusing it. So we're going to provide it under home care, home care services, but the nurses we're going to assign are going to be the hospice nurses. And then, so once we were in the home and they, had the service and we had the time to chat with them and say, if you went over to the hospice benefit, here's what you get for that. For example, all your medicine related to your illness are paid for. So for people who are saying, I don't have the money to pay for my medicine, my pain medicine or my anxiety medicine or whatever, say, well, if you go over to the hospice benefit, you'll still have us as your nurses, but the hospice benefit will pick up that charge. So it's an economic change that goes along with the sort of a mind change. They'd be like, so I don't have to worry about how I'm going to pay for my medicine? No. And if you need a hospital bed, we can just bring that in. And the other piece is that it's for patients and their families, right?
Right.
So the families get a year of bereavement services following their death. So it's an extra layer of support from that point of view. And if you've got young kids or whatever, those extra bereavement services are going to be vital to their grieving process. So there was that workaround. Now, I don't know if that's if they still are doing it that way, but it was the same nurses. They just were being reimbursed under home care as opposed to palliative care. And palliative care has way better benefits for the patient.
Okay.
Well, so I think that leads us to the third half of our program, where we have a segment called Where There's a Will, There's a Way. And our chief obituist, who's such a bitch, Charlie, is going to discuss interesting wills. So, Charlie, what do you got for me?
Leona Helmsley was a very successful businesswoman. Her nickname was the Queen of Mean. When she was convicted...
Queen of Mean?
The Queen of Mean, yes.
I thought that was my nickname.
No, she copyrighted it, I think, too, so just be careful. She was convicted of federal income tax evasion and sentenced to 16 years in prison. But,
Whoa.
Yes, but she only served 19 months. She was also famous for saying, we, meaning the wealthy, we don't pay taxes. Only the little people pay taxes. So, at the time of her death, Leona's estate was worth around $4 billion. $10 million of that was left to her brother, and $5 million each to two grandsons, and nothing to two other grandchildren. To her dog, however, named Trouble, she left $12 million, which a judge later ruling that Hemsley was mentally unfit when she executed her will, reduced that amount to $2 million.
Because that makes more sense.
Yes, it does. So, Trouble was flown by private jet to Hemsley Hotel in Florida, where Trouble, not Leona, was taken care of by the hotel's manager. So, Trouble's annual expenses amounted to about $100,000 a year. So, this amount covered food, which was prepared by the hotel chef and served on silver and china plates, transportation via a Mercedes stretch limo.
Well, that's how I get around.
Well, yeah, don't we all? $8,000 a year for grooming. Groupons would have reduced that amount, but I guess no one thought of that. And,
absolutely.
And $98,000 a year for a full-time bodyguard, or a dog bodyguard, or a dog good. Well, whatever, but a bodyguard. And actually, it turned out Trouble received a lot of death threats.
Why?
I don't know. I knew you were going to ask that. I don't know. I don't know. I would have to research that further when I research the
cheesecake.
The chocolate cheesecake, yes.
Yeah, we will all hold our breath.
Yes. So in the end, in Trouble's end, Mrs. Helmsley wanted to have Trouble interred with her in her mausoleum in Sleepy Hollow, New York. But New York law prohibits interment of pets in human cemeteries, so Trouble is cremated.
So then is she cremated and with Leona?
Okay, so when I'm researching that chocolate cheesecake, I will also look into this further. Other celebrity pooches just never really had this problem.
Hey,
Snoopy,
inquiring minds want to know, Charlie.
But Snoopy never had this problem. Snoopy laid back on top of the doghouse, munching on bones, looking through the newspaper. Scooby-Doo never had this problem, but hanging out with Shabby and...
Yeah, but neither of them ever died. So when we say everyone dies, it's everyone except cartoon characters.
Well...
I hate to break it to you, Charles.
What about Bambi? Oh, not a cartoon character. Yes.
But she...
Well, actually, it wasn't Bambi, it was Bambi's mother.
It was Bambi's mom. That's right. I was just trying to think of what's the storyline on that.
Oh, wait a minute. I didn't think of this. Dumbo as well. Dumbo's mother. No, wait a minute.
No, she didn't die.
Dumbo was just taken away.
Right. When I was pregnant with my first daughter, with Leah Rose, I really wasn't aware of what my hormones were doing. And for some reason, I was watching Dumbo. God, don't ask me why, because I didn't have any kids. And when they took the baby away, they took Dumbo away, I just cried. And, when she puts out her trunk and she rocks them and sings that song,
right, yeah.
I was just sobbing. And I thought, oh my God, something's really wrong with me. Yeah. Anyway, back to Leona. So she took an awful lot of money and left it to her dog.
Yes. She also left, I think it was about $100,000 to a chauffeur. And actually, it was interesting. The stipulation with her, with the two grandsons, was that they had to visit their father once a year, and if they did not visit, they'd be cut off. Yes.
Well, that's one way to keep those family bonds nice and healthy, right?
Yes, bonds, stocks, securities. Yes, exactly. But actually, when the judge reduced...
Chocolate cheesecake.
Yes, but I'm telling you, it doesn't seem to exist anymore. Just a plain, simple chocolate
All right.
cheesecake without any foo-foo
Thank
stuff
you,
in it.
Charlie, for that obituous bitchy report.
We are developing an ongoing segment called I Wouldn't Be Caught Dead Wearing That. And would like you to send us pictures, along with the story behind the picture, of you wearing something that you had said you wouldn't be caught dead wearing. But you wore it anyways. We will discuss them on an upcoming podcast, and the winner will receive an Everyone Dies t-shirt. To reach us, you have a few options. You can email us, info@every1dies.org. That's info@everyonedies.org. And the 1 is a number. By snail mail, P.O. Box 851891, Yukon, Oklahoma 73085. Our website, everyonedies.org. And again, 1 as a number. And at Twitter, @everyonedies. EVERY, the number 1, DIES. Thank you for listening. Please stay tuned for future episodes of Everyone Dies. Our thanks to our CEO, retired Major General David, our producer, Sandy, John, our technical advisor, and our friends and family who are helping make this podcast a reality. This is Charlie Navarrete.
And I'm Marianne Matzo.
And we look forward to talking to you soon.
Goodbye.
Bye.
This podcast does not provide medical advice. All discussion on this podcast, such as treatments, dosages, outcomes, charts, patient profiles, advice, messages, and any other discussion are for informational purposes only and are not a substitute for professional medical advice or treatment. Always seek the advice of your primary care practitioner or other qualified health providers with any questions that you may have regarding your health. Never disregard professional medical advice or delay in seeking it because of something you have heard from this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Everyone Dies does not recommend or endorse any specific tests, practitioners, products, procedures, opinions, or other information that may be mentioned in this podcast. Reliance on any information provided in this podcast by persons appearing on this podcast at the invitation of Everyone Dies or by other members is solely at your own risk.